The for those of you who, this is all about letting you know the results of the BedMed trial. Everybody who was invited to this webinar was a participant in the BedMed trial. And so this is about letting you know what I know about antihypertensive medication timing, why we did what we did, what happened in the trial that you were participating in, the ins and outs of it, and what we learned. We want you to be able to ask questions, and as you can see printed in front of you, if you have a Gmail account, you will be able to ask questions in the comments. YouTube will recognize you. If you don't have a Gmail account, then the only way to get questions to us is to email us. So Michael, Farah, Anna, the people who you talked to over the last few years or more in the study are monitoring the BedMed email account. So that's bedmed@ualberta.ca. And they're going to be collecting all of the questions you have, both from the comments and from the email, and putting them into a Google Doc for me to look at. So I'm not going to actually see the comments themselves, but I'll see what they put into the document for me to answer. So I want to start by saying thank you to all of you. I can't tell you how important it was to us that you participated in the study. We couldn't have done it without you. In the early days of the trial, when we were working really hard to figure out how to entice people to participate in the trial, we spent a lot of time trying to understand why people were signing up. Were you hoping to get a health benefit for yourself, or other sort of reasons? It was really clear that pretty much everybody was participating for very altruistic reasons. You're really thinking outside of yourselves and trying to make the world a better place. And you were exactly the kind of neighbors all of us would like to have. And thank you again for making this possible. So I'm Scott Garrison. I'm a family doctor and a professor in family medicine at the U of A. I was the principal investigator for the trial. So which means I did hold the grants, which came from government sources, from the Canadian government and from the Alberta government. But I otherwise have no financial conflicts of any kind. Obviously, I'm going to be biased about the trial, but I have no financial linkages to disclose. No disclosures, except perhaps to say that I kind of feel like I'm giving my own eulogy when I give these presentations, because the trial went on for so long. So some of you were in it you probably figure you were in it for a very long time. Some of you could have been in it for up to 6.5 years. But for me, going back even farther, getting started, it's about a quarter of my life doing this trial. When we started doing it, my hair was black with a little bit of gray. It's now gray with a little bit of black. And we still have another year to go to finish off all the other papers. And by the time we finish, it'll have been enough time to span the terms of 4 US presidents. It's all been about becoming a learning healthcare system. That's what my team and I have been working towards. The government already routinely collects information about what happens to people. If you get admitted to hospital for a stroke, that information is collected. If you have a medication prescribed, or if you have something else sort of befall you health-wise, those events are collected. So the idea was that if I could get my family physician colleagues to randomize some very simple things, we could learn how to use the tools we already have more effectively and get better health outcomes. And you probably think that this is already happening routinely, but it's not. It requires some organization. It requires things to be randomized, because if you don't randomize the treatment options, there's lots of things that can mislead you. into thinking that there's benefit or harm when there isn't. So that the goal was to create a network which would do this work, and BedMed is the first large trial that that used that network. So what I'm going to talk about why medication timing might matter. I'm going to then talk about what we know about blood pressure medication timing from the other trials outside of ours that exist, and then I'm going to talk about BedMed and a related trial you probably didn't know existed called BedMed Frail. We actually conducted 2 different trials and then put it all together. So why might medication timing matter? Well, we live in a world where there are lots of physiologic stresses that we need to adapt to, which are very cyclic. So the one that you're going to think of would be the seasons. The world changes from being warm to cold, with food being abundant to not abundant. Other mammals adapt to that by, if you know that change is coming, if you can adapt your physiology in advance, you have an advantage. So you'll increase your fur thickness as winter's coming, put on body fat. In the summer, females will go into estrus. Males will get more aggressive and grow horns on their head. And you can see those changes happening in mammals. You don't think of it happening in humans, but it actually does. Long bones grow more quickly in children. In the summer months, the immune system is more reactive in winter, and we retain a little bit more water in our bodies during the warm summer months, in case that's going to be needed. But the other cycle, which is predictable, is the cycle that happens over a 24-hour cycle, right? So temperature varies, light varies, but in particular, we go to sleep. We go into a maintenance state for a good 8 hours a day. And you can't see the changes that are happening in our bodies, but there are very substantial changes that happen depending on the time of day. So one of the main ways that we know this comes from some studies in mice. If you sacrifice a mouse at different times of day and you look at the organs, you can see which of the mouse genes are being expressed at different times of day. Meaning, so the genes say, how to make all the various enzymes and other proteins that you need for your body. You can look and see when are those enzymes and other things being made. And you would have probably thought that it would be kind of constant, but actually it's not. So for almost half of the genes in your body, rather than being constantly produced, the proteins of those genes are produced in rush hours, either at dawn or at dusk. So, and a lot of those proteins are the targets of the drugs that people are given to treat various conditions. You can't sacrifice humans and look to see the same sort of things, but we do take biopsy specimens of people all the time. And if you look at the time of day and what genes are active, the same thing is happening in humans. Right? We have rush hours of making the various enzymes and things that the drugs target, that can be either in the morning or in the evening. So what might that mean? Well, it might mean that the time that you take medications could matter. So in particular for drugs that have what we call a short half-life, which just means like when you ingest it, it doesn't stay in your body at a constant rate for a long time. It kind of goes up and then it falls down again. So for those, it might matter if you're taking it closer to the time where the target of the drug is being produced more readily, or drugs that act on the liver. The way your body is designed, everything that you ingest being absorbed from the bowel is fed first through to the liver before it gets anywhere else in your body. So the liver never sees constant levels of a drug. The liver sees a big hit of the drug around the time that you ingest it, and then that'll fall down to the sort of levels that the rest of the body sees after that. But so if the drug is targeting the liver, then timing could make a difference. And pretty much any drug, if the absorption or the metabolism of it had some sort of a circadian modulation. So, but does it matter, right? Theoretically, it could matter. Does it matter? And we actually know extremely little. There's very little research that has been done on the timing of medications. So we do have some evidence to suggest, if you take a acid lowering medication called a PPI, common medication, it is better to take that in the morning as far as lowering acid. There's some evidence to suggest that aspirin taken in the evening might more effectively inhibit platelets, like make your blood less likely to clot. But that's only been done in a lab. There are no studies in humans to tell you if that makes a difference to heart attacks or strokes or bleeding risk. The only thing that we really have large studies about is blood pressure medication. And the reason for that is that there is yet another reason to think that timing might matter when it comes to blood pressure medicine. So your blood pressure, a normal person's blood pressure, is higher during the day than it is overnight, which you can see in this here, right? So blood pressure is higher during the day, and then it falls once it's getting into the evening. It isn't even actually because you fall asleep. Like your pressure just has this rhythm where it goes lower as the evening hours are coming on. And it turns out that the overnight pressures, the pressures while you sleep, are more predictive of whether someone's at risk of having a heart attack or a stroke than is blood pressure during the day. So it's worse to have high blood pressure overnight than it is to have high blood pressure during the day. So we knew that. And if you're taking your blood pressure medication at bedtime, and if it's for most drugs going to be more effective in the earlier hours after you've taken it, if you took your blood pressure medication at bedtime, you might be preferentially lowering the overnight pressures. And so you might be preferentially improving the blood pressures that matter more to heart attack and stroke risk. That was the reason why people looked at this to begin with. And could it be that bedtime blood pressure medications lowered cardiovascular risk better? So I'm going to tell you the other blood pressure trials findings, and after that I'm going to tell you about ours. The trial that started it all off was called MAPEC. It was a trial that was out of Spain. Dr. Hermida and his colleagues had published a paper in 2010 where they took people who were they were referred for ambulatory blood pressure monitoring, the 24-hour blood pressure monitors that some of you might have ordered, your family doctor might have ordered that for you. They took people who were arriving at a clinic for that, and they enrolled them in a trial, asked them to enroll in a trial where they would randomize the time of day that they used their once daily blood pressure medications. So they had a little over 2,000 people, 2156, who participated in the trial, and they followed them for a number of years. The average number of years of follow-up was 5.6, and they looked at a collection of things: death from all causes, heart attack, stroke, heart failure, hospitalizations, a variety of things. And This paper was very provocative because it suggested a huge benefit, a huge reduction in that composite of bad cardiovascular events if you took your blood pressure medication at bedtime. It never changed practice. And the reason it didn't change practice, there are two sort of general reasons. One of them was it just simply seemed too good to be true. If you treat blood pressure versus not treating it, you get about a 30% reduction. So this was a 61% reduction on top of the reduction you already got from treating blood pressure. And other things that we do, like taking statin medications, that gives you about a 30% reduction in risk. Aspirin gives you a 15% reduction in risk of those cardiovascular events. Is it possible that you could have a benefit that's that big? The only one that I know of that's that big would be for people who have atrial fibrillation if they're taking an anticoagulant. That's about the only thing that gets up to that 60% sort of risk reduction. So that made it hard to believe. And also, they published their paper in an obscure journal called Chronobiology International. It's like, if you're an academic, if you're a researcher, why wouldn't you publish this in a major journal? There are lots of other nerdy reasons for skepticism. So a lot of the slides that I'm showing you have a lot more detail in them. I'm assuming some of you might be academics, some of you might be interested in this, and this will be available for you to replay afterwards, so you can go back and hold on the slides and see some of the individual details. Otherwise, I'm just going to talk in high level to give you a sense of it. So there were sort of nerdy reasons to be skeptical, and by that I mean there were things that you would expect somebody to tell you in the write-up of a randomized trial, so that they could be confident in what was done, and a lot of those things were missing. So that was the other reason why academics were skeptical. The same authors, exact same authors, went from that. In fact, even before that study finished, they started a second trial, which was in primary care patients. So people being recruited out of family medicine clinics. This trial, so this came on after BedMed was already started. This was sort of halfway through the BedMed trial being conducted. But those same authors, those same Spanish authors, published another trial, which was a huge trial. They had 19,000 primary care patients, 61 years of age on average, 44% were female, 24% had diabetes. And again, they randomized them to either take their once daily blood pressure meds in the morning or at bedtime. And they followed them for average of 6.3 years. And again, they reported a large reduction in heart attacks and strokes and, in this case, cardiovascular death, some various things that were bad and vascular related. They were 45% lower in the group who took their medications at bedtime. So this was published in a good journal. It was published in the European Heart Journal, but again, it didn't change practice. And the reason it didn't change practice, well, number one, it was the same investigators, so you can't really validate your own work. But one of the main things was that if you looked at, if you calculated out what the death rates were for non-cardiovascular events, right? So dying from pneumonia, dying from a car accident, you have surgery and there's a complication and someone passes away, things that had nothing to do with the vascular system, that those deaths were also reduced by a comparable amount, by about, in this case, 42%, which didn't seem to make sense. How do you get a 42% reduction in non-cardiovascular death from a blood pressure intervention. And then again, the same sort of nerdy reasons were there. There were a variety of things which would have been felt to be important to be reported, which were not reported. So in the wake of the MAPEC trial, right? So again, IGEA had not been published yet, but there were two groups that looked to try to reproduce this work to see if it's real. And we did think that, we didn't expect that we were going to find a 61% reduction, but we thought and hoped that we were going to see benefit. That's why we launched the study to begin with. But there were two groups. So there was a group in the United Kingdom that did the time study. And then there was our group that did BedMed, which is the study you were in. And we did BedMed Frail, which is a completely separate study which happened in nursing homes. So the time study, they published a couple years ago. They finished before we did. It was an enormous trial, 21,000 patients. They were from primary care, so most of them were recruited the same way that you would have been mailing letters to all of the patients with hypertension attached to primary care clinics. It was different in the UK. They're set up to do this on a national scale. This is my guess based on the numbers of letters that were mailed, they probably had over 8,000 physicians that had facilitated mailouts to their patients with hypertension. And then they also did something which was very novel, which was they, rather than interacting with a person, as you did, when you called to enroll in the study, they had set up a website so that you didn't talk with a person, you interacted with the website, and you did things by email, which has pros and cons. The pro of it was that you could handle an enormous influx of people calling to enroll in a short period of time. But they had the same intervention. People were randomized to taking their blood pressure medications in the morning or at bedtime, and they looked at a composite of major adverse cardiovascular events. So in their case, it would have been cardiovascular death, meaning death from cardiovascular causes, and not counting other reasons for dying, or hospitalization for stroke, heart attack, or threatened heart attack, or heart failure. They followed them for an average of 5.2 years, and unlike the previous studies, they found no difference in that composite primary outcome. So when you see the results reported, both here and then for ours, you'll see this down at the bottom. It says HR and then 0.95. So HR stands for hazard ratio. You can think of it like what's called a relative risk, which probably still doesn't mean that much to you. But there are fancy things you do with the statistics that take other things into account that you know about people that put them at risk, where you can actually make a more refined estimate of what the benefit of the medication actually was. But if you want to think of it most simply, most crudely, this number is taking the event rate in the bedtime group, right? So, per year that we were able to sort of follow people, how many people have these events happen in the bedtime group, and you divide that by the event rate in the morning group. So if something made absolutely no difference, then this number would be 1. If something is reducing the event rate of the bad stuff substantially, then it goes lower, right? So in the MAPEC study that started all of this off, when I said that they had a 61% reduction, their hazard ratio would have been 0.39. So, and the other thing that comes here, there's something called a p-value. So this tells you what's the chance that you would have found a difference that was this big or bigger just by fluke. And so here, there's a 53% chance that you would have found a difference, like a 5% difference is what this is, or more, just by fluke, right? So this is, the kind of differences you'd expect when there is no difference between the two treatments. Time was a well-conducted, well-reported study. The only thing that maybe people might wonder about would simply be that the population, because of how they recruited, and also because they excluded people that had twice daily blood pressure medicines. A lot of you, if you have coronary artery disease or heart failure, like you'll often be taking a medication twice a day. Or if your blood pressure is really hard to control, you might be taking that blood pressure med twice a day. So because they excluded those people, they tended to be people that were at lower risk. So that would be the only thing, like comparing to BedMed, the outcomes we had were not exactly the same. So it's kind of apples to oranges to compare them. But if you look at one thing which would have been exactly the same in each trial, as far as how it was measured, would be all-cause death. And so all-cause death in BedMed was about 50% higher than in Time. So the people in BedMed had higher, I would say typical for primary care, but higher risk of events. So what did we do? Well, we actually had two separate randomized trials. There is the BedMed trial that you were all in. So that was recruiting through primary care, largely through family doctors mailing letters to all of their patients who had hypertension to see if they were interested. But we also did a study called BedMed Frail. So BedMed Frail was done in nursing homes in Alberta. And the reason that we did it, we did two trials, is that frail older adults are underrepresented in typical randomized trials. We really don't have good information for them. The stuff that we know from younger, less complex medically populations gets generalized to older adults, either because the exclusion criteria in the trials explicitly excludes people like over a certain age, which they do because they're doing it because they think for safety reasons, or there'll be certain conditions you can't participate if you have kidney insufficiency or other things which they're more likely to have, or certain medications that you can't be on to be in the trial again. So people who are on more medications more likely to be excluded. But also, if you think about it, the people that enroll in a trial, like if you're towards the end of your life, if you don't have a lot of energy, if things are a struggle, like you're not going to be the person that's calling to enroll in a trial. So pretty much everything we study, the sicker, the more complex sort of individuals are usually not included. And that's problematic because, the risks and benefits of everything that we do could be meaningfully different in somebody who was studied, who has just the condition of interest and maybe one or two other medications, versus somebody who has 5 or 6 different conditions, 6 or 7 different medications. Like the chance of an interaction between those medications or some other side effect happening is much, much greater. So part of what's important to us is to be providing information not just for the average person that's willing to enroll in a trial, but also for this frailer group, which seldom ever gets studied. So we had done both trials. We did it thinking that bedtime was still going to be better, but we also wanted to look at risks because these people were at greater risk of having those risks. So for instance, we talked about if you're taking your blood pressure medication at bedtime, you're going to be lowering the overnight pressures. Those are already the lowest pressures of the day. So you're going to be reaching new lows of blood pressure than you had before. And might those new lows be problematic? So either for falling lightheaded and falling when you get up to go to the bathroom at night, and fracturing. Or if you're bedbound, you probably need a certain amount of blood pressure to perfuse the skin. If your pressure is going to be lower overnight while you're lying, are you more prone to bed sores? Decubitus ulcers is the medical term for that. Or if you have dementia, maybe a vascular dementia, maybe you have some narrowings in blood vessels, and you need a certain amount of pressure to get past it. Could this lower pressure make cognition worse for them? There's also something called sundowning for people who have dementia, which means people get more agitated, maybe more confused as night is coming on. That's a common scenario in people who have dementia. And it was conceivable, this is just a theory, it was conceivable that maybe that phenomena of sundowning could be happening because blood pressure is lowering at the same time. So if that was true, could behavior problems get worse? Could the sundowning get worse? So we also wanted to look at that. So let's start just with BedMed, again, so the trial that you were in. The first patient was recruited in March of 2017. The last one was recruited in May of 2022, and we followed all of you until the end of December of 2023. Again, it was a randomized trial. We did the equivalent of flipping a coin for each of you as to which group you were in. Of course, it's not really a coin, it's a computer. Where we had no control over which group that you would be in. We couldn't foresee which group you were going to be in, and we couldn't back out of which group you were in. All those are important things to believability in a study, in a trial. We recruited people in 5 different provinces. 3/4 of them were from Alberta, largely because that's where I'm located. That's where most of the ability to present to physicians had come up. But we also had participants in British Columbia, in Saskatchewan, in Manitoba, and in Ontario. 436 primary care providers in 61 different cities mailed recruitment packages to all of their hypertensive patients, and helped with the timing changes. If you see your doc, thank them again for me. Like all of the docs that participated in this, they were all volunteers. Nobody was paid a cent. Unlike, like I say, like in the UK, they managed enormous recruitment, but there's also a fee structure. There's a part of the work remuneration for those physicians is to facilitate these mail-outs. Where in Canada, we don't have that kind of a setup. Anything that the doctors are doing, they're doing on their own time for free. We had administrative health data linkages for 92.6% of people. So that's, remember in the beginning I said that we're able to, the government knows when you have a heart attack, when you have a stroke, from the data that comes from the hospitals. And we were able to access that data to track what was happening to you. We were able to do it in Alberta, in British Columbia, and in Manitoba. We were not able to do it in Saskatchewan or Ontario. So in that case, we really relied on the information that you were providing to us. We had a patient working group. So these are people who were with us from the beginning of the study. There are some research assistants scattered in there. Farah is in there off to the right behind me. But they helped us craft all the patient-facing materials. They helped us with what questions we were going to be asking, what data we were going to be gathering from you. They helped early on in the trial. We really needed to try to improve the response rate to the stuff to get a higher rate of people participating. They were really instrumental in doing that, including creating a social media campaign. So we actually had Google and Facebook ads, which ran in order to get some more people in, besides just from the doctor's letters. And this is what that looked like.
Did you know that the time of day when you take your blood pressure medication might be important? A European study suggests that taking blood pressure pills at bedtime instead of in the morning may reduce heart attacks and strokes by more than 50%. The University of Alberta is leading BedMed, a Canada-wide blood pressure study, to determine if these findings are true. With your help, we can find out. BedMed randomly assigns participants to take at least one of their current blood pressure medications in the morning or at bedtime for the duration of the study. The study will then follow participants' health outcomes for up to 3 years by phone or online survey. This study could change the way high blood pressure is treated for millions of people around the world. Apply now or contact the study team to learn more. BedMed, it's about time.
Interesting in that it said for 3 years. I think, as you all know, the study went on longer than that, which we needed to do because we needed to have a certain number of outcomes, and we obtained that by observing longer. We did think it was going to be done in 3 years when we started. To be eligible for the trial, you needed to be an adult, you had to have hypertension, you had to have at least one once daily blood pressure medicine, but you could also have twice daily blood pressure medicines as well. You had to be community dwelling, meaning because we separately were studying people that were in nursing homes. The only real main exclusion criteria was having a condition called glaucoma. And the reason for that is that there's observational evidence that people who have glaucoma, which is a condition where typically you have elevated pressure inside of your eye, and it's kind of it's thought to be like an ischemic. You're not giving enough blood flow to the back of your eye for the health of the eye, and if those people have lower overnight pressures, that their vision can deteriorate more quickly. So we wanted to exclude anybody that knowingly had glaucoma. The other exclusion, which happened very rarely, would be sleep disrupting shift work. So if you had more than 3 shifts per month during your regular sleep hours, then we excluded you. So that resulted in you participants being on average 67 years of age, 56% were female. You had, the comorbidities means like other medical conditions. So you had roughly the percentage of other medical conditions we would expect in the primary care population. About 1 in 5 of you had sleep apnea. A little less than that had diabetes and some other conditions. Half of you had just a single blood pressure medicine. About a third of you had 2 blood pressure medicines, and the other 11% had 3 or more. Which medicines you were taking was very well split up amongst the main different types that people are on. And the intervention, as I said, was taking all once daily blood pressure medicines when getting ready for bed. If you didn't tolerate that for some reason, we asked you to try to take it at dinner rather than switching back to morning. Whereas the control group was taking all once daily blood pressure medications upon waking, which is what most people were doing when they entered the study. We followed you at 1 week, 6 weeks, at 6 months, and every 6 months, typically by phone. But some of you also opted to have those later follow-ups by email survey. And we had what's called a blinded adjudication committee. So there were 3 family physicians who had no idea whether you were in the morning group or the bedtime group. And they were provided the information that you gave us about the health events that had happened to you. And they were provided the electronic health data from the provincial governments that were participating. And if those agreed, I mean, if you said you had a heart attack, if the claims data said you had a heart attack, great, that event was accepted. if we only had, if there was a disagreement, or if we only had that from one source, right? So only from you reporting it, but there was nothing in the claims data, or vice versa. Maybe we lost touch with somebody, weren't able to contact them, and we had a claims event that we wanted to corroborate if it happened. So if we only had it from one source, then we contacted your family doctor and asked them, can you please confirm whether or not this happened? The primary outcome was a composite outcome, right? So any of these things would qualify. All-cause death from any reason, which we did because the MAPEC study had shown a large reduction in all-cause death, and it's much more obvious when someone died. Like, you can be very, for certain that happened, whereas some other studies will use cardiovascular death, like death from a massive stroke or a heart attack, but sometimes it's actually hard to tell whether the death was due to that or not. So because it was more clean cut, because MAPEC said that this was reduced by a large amount, so we had all-cause death or hospitalization or emergency department visit for a stroke, for acute coronary syndrome, which includes both a heart attack and also what we would call unstable angina. It's like a threatened heart attack, but there isn't actually any damage to the heart muscle. Or for heart failure, where your heart is just not pumping as effectively as it needs to be, and you can get some symptoms as a result of that. That's also something that's very influenced by blood pressure. Secondary outcomes were each of those things individually, and all-cause unplanned hospitalization or emergency department visit, trying to sort of capture a whole bunch of things that could be different. And we had safety outcomes. So we were looking at whether you felt that you were lightheaded or feeling faint or were falling. We looked at whether you broke a bone, in particular whether you had broken a hip, as being the worst of the fractures. We looked at visual changes. So some people might have glaucoma and they didn't know that they had glaucoma. So we wanted to check and see if you thought that your vision was deteriorating over time. That's subjective, but at least it was something to track that. And we also looked for new glaucoma diagnoses in the electronic health data, which we were able to collect. And we looked at things that would have to do with cognition. So it could have been that bedtime made things better, because treating blood pressure effectively is supposed to help prevent dementia. But it could have also made things worse for the reasons that I explained before. If you have a vascular dementia, you might need a certain amount of perfusion pressure, pressure to get past an obstruction to feed the blood, to the brain. So we assessed your cognition at baseline with what's called the short blessed test. If you remember, asking you some questions to get you to remember certain things and repeat it. And we did that again at 18 months to see if there was any difference in the two groups, whether there was a decline in either of the groups. We also looked at whether we said new impairment consistent with dementia, which means scoring bad enough on that test, or if there was a claims diagnosis from a physician which said dementia. We also included in that nursing home admission. In Canada, most nursing home admissions happen because somebody has dementia. So that was another indication. We, Michael Farah and Anna and crew talked to over 5,000 people to assess them for eligibility. 3,357 of you were eligible and wanted to participate and were randomized to morning or bedtime, equal numbers roughly. And it was really good as far as not losing track of you as time goes on. That's something that's important to look at in the study. Only 3% of people withdrew or were lost to all follow-up. That number is low because, again, we had the ability to continue to track most people using the electronic health data. Most people, if they dropped out of the study, were fine to let us continue to track what was happening to them that way. And an additional 16% we say were lost to active follow-up, and that means we weren't able to keep tabs on you, by phone or by email, maybe because you might have fatigued participating every 6 months if you were someone who was in it for 6.5 years. That's a fairly long time. The average length of time that someone was in the study was 4.6 years. Like I mentioned before, it could have been up to 6.5 years. It was quite good as far as whether you were able to take the medications at the time of day that you were randomized to take it. So 83% of once daily blood pressure medications were taken at the time they were supposed to be in the bedtime group versus 95% in the morning group. Of course, it's higher in the morning group because for most people, we're not asking them to change anything. That's when they were usually taking it when they entered the study. But this figure, so this is broken down by the different medications. These are ACE inhibitors, ARBs, angiotensin receptor blockers, beta blockers, calcium channel blockers. Combination pills it means you're combining a diuretic with a non-diuretic, like one of these other meds that are here. And then diuretic medications, mostly hydrochlorothiazide. And the green is the people that are the medications that are taken at the time that they're supposed to be. So you can see it's quite good for ACE inhibitors, quite good for angiotensin receptor blockers. It fell off with the beta blockers. The reason for this is a lot of beta blockers are taken twice a day, and we weren't really asking the doctors to change the timing of meds that are taken twice a day. So a lot of those continued the way that they were taken. Calcium channel blockers were good. Combination pills were pretty good. It also fell off a little bit for diuretics. A lot of patients, a lot of physicians too, had concerns that if you took your diuretic at bedtime, that you might end up getting nocturia, like needing to pee in the middle of the night, that could disrupt sleep. We actually did a study in the beginning of BedMed. We thought, we would include everybody because all of the other studies also include people with diuretics. But we thought we would check, and if people were struggling to take diuretics at bedtime, we thought, okay, well then we would change the exclusion criteria and inclusion criteria so that if someone only had a diuretic, we would exclude them. But when we did that analysis, it turned out it wasn't really needed. We compared people who only had one morning blood pressure medicine when they entered the study, who were asked to switch that to bedtime, and we compared those who had the diuretic that was switched to bedtime to those who switched something else to bedtime. And like 75% of people who were switching diuretic to bedtime didn't have any trouble taking it at bedtime. 14%, so compared to people switching a non-diuretic to bedtime, an extra 14% of people experienced nocturia as a problem. So it does increase nocturia. If there was a compelling reason to take diuretics at bedtime, though, most people could do it. So did it make a difference? So I think you all know by now from the email or the postcard that we would have sent you, not postcard, but the letter that we would have sent you, it didn't. So this is our primary outcome, right? So this is the composite of all-cause death or hospitalization for stroke, heart attack, or heart failure. And so again, like I was saying, this is the number to look at. So our hazard ratio was 0.96, right? So again, there's fancy things that come in here to make the estimate more refined, pushing it up or down. But if you basically think of it like it's the rate of events in the bedtime group divided by the rate of events in the morning group, And it would be 1 if they were exactly the same, and it's almost 1. It's 0.96. The p-value that I told you about, so the chance that you would have found a difference this big, or or uh, uh, or less, um, uh, by chance alone is 70%, right? So this falls well within what you would expect, if there really was no difference, no benefit. We looked at the subgroups. So we did what's called subgroup analysis. So we took smaller populations of people, looked just at men or just at women, just at people over the age of 75, just at people who were physically frail or who had hard to manage high blood pressure, meaning you're on like 3 or more blood pressure medications, or just certain comorbidities, diabetes, heart failure, and so on. And each of the individual medications, did you take an ACE inhibitor at baseline? Did you take a angiotensin receptor blocker? All of the different drugs. So we looked at all of those populations separately, and in none of them was there a suggestion that it made a difference. The same was true for the secondary outcomes. So all those other things that I told you we were looking at, the individual events on their own, the safety things that we were looking at, none of them were different between the two groups. So what about BedMed Frail? So this is the nursing home study. So we did it so we had 17 continuing care wards. That's within 13 distinct facilities within Alberta. We had let all of the residents know, all of the families know, all of the physicians know that the study was happening and that the timing of blood pressure medication might be changing, so that people could opt out themselves or their loved one or their patient if they didn't want them to participate in the study. In Alberta, one of the reasons we were able to do this was regardless of what time of day you were using your blood pressure medicine when you get admitted to a nursing home, the nursing homes were defaulting to morning use. And it wasn't a patient-centered decision, it was just standard, like this is what the facility does. And so because the only evidence at the time we started this was that bedtime might be better, the ethics board said, yes, it's ethical to if you let everybody know and you're going to be changing the timing to the only time that suggests maybe there's a benefit that this could be done. So we weren't interviewing anybody, we weren't getting any information from them directly. All of the information about what happened to people came from the administrative health data, the electronic data that's being collected on everybody. The inclusion criteria were similar, so were the exclusion criteria. The intervention was taking all once daily blood pressure medication at bedtime. The control was a little different. The control was no change in timing because, again, we thought bedtime was going to be better. We didn't want to take anybody from bedtime and move them to the morning. So if you happen to be taking it at bedtime, we didn't change anything. But it's largely morning use, as I had said. And again, it's randomized at the patient level as to which group that you would get into. The primary outcome was exactly the same as in BedMed, so were the secondary, main secondary outcomes we were looking at, heart attack, stroke, heart failure admissions, all-cause unplanned hospitalization. Although I should say, in case I forget to say it later, people don't get sent to hospital all that much if you're in a nursing home for events like maybe they had a heart attack or maybe they had a stroke. A lot of them are managed on site, and the death rate is really high in this population. The average lifespan for someone that's admitted into a nursing home is only about 18 months. So the primary outcome for BedMed Frail is driven largely by death. But we were looking at all of these other things, including the safety outcomes. And as I mentioned, the safety outcomes, we're looking at falling, which is recorded in the nurse's component of the electronic health data. Every 3 months, they talk about what's happened with the resident in the last three months. Sorry, since the last report, last year, and they have an element which is, have you fallen in the last 30 days? So we could look at that. We looked for fractures. We looked for deteriorated cognition, which again, the nurses are talking about relative to the last report, at problem behaviors, like being aggressive, being, the things that come with sundowning, difficult to manage, wandering, like that kind of thing. And we looked at skin ulcers. In this case, we randomized 829 patients. We, unlike in BedMed, where everybody that got randomized was analyzed, we only analyzed 776 people in this study. The reason for that is that a lot of the facilities were fitting this in with other work. This happened at the same time as the COVID pandemic happened. And because of COVID, and in some cases because of other things, there was often a delay between when the randomization happened and when the pharmacist was actually able to make all of the timing changes. So we treated the date of the timing changes as being the date of the randomization, and then anybody in the interim who became ineligible, which essentially meant they died or they stopped their blood pressure meds or they moved out of the facility, we excluded all those individuals from the trial. So I think that was a fair, we call it a modified intention to treat. I don't think that changes the analysis meaningfully. There was very few people that dropped out. Only 1.7% of eligible patients told us that they wanted to drop out of the study. 4% withdrew or lost the follow-up. That's essentially people that moved out of the facility, moved elsewhere. And the median follow-up, it was only 1.1 years, but the study itself ran for close to 4 years. A lot of that, again, is just because the death rate is so high. As far as the percentage of drugs that were taken when we wanted them to be taken, if you look at the percent that were taken at bedtime, so the blue here is the bedtime group. So about 70% of antihypertensives were taken at bedtime in the bedtime group, compared to about 15% in the morning group. This actually also includes twice daily medications. We counted them as being like half a dose taken at bedtime and half in the morning. So that is making the numbers look a little bit worse. We also had a per protocol analysis which we had predefined, what the criteria were. But we had 13 of 17 facilities which we considered to be high performing as far as making the timing changes. And just looking within those facilities, so we had about 80% of the antihypertensives being taken at bedtime in the bedtime group, again, compared to 15%. Just in case I forget to say it, the results are exactly the same in this per protocol analysis of the facilities that managed to do the timing changes the best. The results are identical for both. The patients that were in it, on average, they were 88 years of age, 73% were female. The vast majority had dementia and pretty high rates of these other things like chronic kidney disease, diabetes, in about half of people, each of those, heart disease, like coronary artery disease, really high rates, as you'd expect. Most people had a single blood pressure medication, almost about 60% of them. 30% had two, and about 9% had three or more. It was a little more calcium channel blockers, ACE inhibitors and ARBs, a little less so beta blockers and diuretics. And again, statistically speaking, it didn't make a difference. So the hazard ratio that I told you about here, it's 0.88. Again, lower numbers are more meaningful. A number which is roughly 1, means it doesn't work. This time, though, you need to hedge a little bit. Like statistically, it wasn't different between the two groups, but this is starting to get, so this would be like a 12% difference. 12% difference in something which is largely death. I mean, most people would think, okay, well, that if that were real, that could potentially be important. That p-value thing, there's a 28% chance that you would get a difference this large or larger if it was just random fluctuation. So the conclusion is that it doesn't make a difference, but I think you have to take that with a grain of salt. There could be some benefit in here that we just weren't able to detect, didn't have enough people, enough events to detect it. If you look at all of the various other outcomes that we were looking at, one of them was different. The all-cause unplanned hospitalization, it was lower in the bedtime group. The hazard ratio was 0.74. So if it were real, it would be a 26% reduction. The trouble with looking at secondary outcomes like this is if you look at enough things, just because there's random variation, something is likely to look like it's different between the groups just by fluke. In fact, if you have completely independent things that you're looking at, by the time you've looked at 13 of them, you've got about a 50% chance that something would look like it was different between groups. So a study can really only answer one question, which is the primary outcome. In our case, that collection of death and cardiovascular events. So this on its own, if the primary outcome isn't different, you wouldn't ordinarily say that it proves this. If you looked at the subgroups like we did before, so this first column here is the primary outcome, the composite of cardiovascular things. This one here is the unplanned hospitalization. And there were a couple differences. So for the primary outcome, if we did it just in men, it did look like bedtime was better. So again, this is the primary outcome was not met. The conclusion of the study is still that there's no difference. But if you were going to say, maybe there's a difference here, and we just don't have the power to show it, it's conceivable that maybe that difference was happening in men. Don't know. As far as unplanned hospitalization, the one thing that was different was in people who were using beta blockers. It conceivably, this was the event rate was the hospitalization rate was lower if you were taking your meds at bedtime and one of those meds was a beta blocker. So again, these could be complete flukes, and we just don't know. So for putting our two studies together, the conclusion is that for people who have hypertension and no history of glaucoma, it seems perfectly safe to take blood pressure medications at bedtime, but there's no extra cardiovascular benefit that's conveyed from doing that. So blood pressure medicines, you are probably the best judge of when you should be taking it. If there's a time that's easier to remember, or because I don't know of any reason you can't take blood pressure meds with other medications, if you wanted to simplify things and take all of your medication at the same time, there'd be no reason not to do that as far as our study shows. Or if you had a side effect that you're trying to avoid. So we talked about diuretics are more likely to cause some small, but some extra urination. So you probably don't want to take it at bedtime, given that there doesn't appear to be any cardiovascular benefit. But also, so calcium channel blockers like amlodipine or diltiazem, or verapamil. So those can cause some ankle swelling. And if you have that you think it's maybe a side effect from your medication, if you take it at bedtime, it's less likely to happen. So looking for things like that, and again, you can be the one that chooses. So my last slide, just leave you with a bit of a cliffhanger. So this is quite intriguing. The time trial, remember that the big UK trial that was also looking to validate MAPEC, that in last June, so more than a year after they published their main paper, they published another paper in a smaller journal. And they said, if you look at people in a different way, if you look at them according to their chronotype, so that means chronotype is the time of day in which you are naturally more alert and active. And conventionally, people would talk about that as you're an early bird or you're a night owl. And what they essentially said was that if people were taking their blood pressure medicine at the same time as they were more active or alert, so if you were an early bird taking your blood pressure medicine in the morning, or you were a night owl taking your blood pressure medicine at night, that it appeared that you had a lower rate of stroke and heart attack. So not much attention was paid to this because it's what we call a post hoc analysis. So once you have all the data and you can look at things any which way, there's bound to be some way that you can look at something which can sort of show a potentially interesting result. And so typically academics, researchers will really downplay things which are considered to be post hoc. And so we are able to address this question with BedMed. I don't know if you remember, I'm sure you probably don't because it would have been so long ago. But the first question that we ask was more of an icebreaker, really, was, do you consider yourself to be more of an early bird or a night owl? So there's more refined ways to get at that question, but that's how we asked it. And unfortunately, we haven't published it yet. We have submitted a separate research letter looking at this. And just because it's conceivable, maybe somebody in the audience right now is in the media. Like I can't afford to have this reported because it would compromise people don't want these things to be released before the paper, the publication. So I can't tell you what we found yet. I will tell you it's quite interesting. And we will send you another email when that publication comes out, which I'm hoping would be hopefully no more than a few months from now. And but so something to keep an eye out for. And so that's the end of the presentation. So I'm going to stop sharing my slides and then look to find, where are we here? Sorry. I'm going to look for questions. So if you guys want to, hopefully you're able to submit any questions either by putting them in the chat or by emailing bedmed@ualberta.ca, and we can try to answer those. Yeah, so I see one. Thank you. Yeah, thanks for talking about the early bird and for the commitment to share follow-up. Yeah, we will for sure. If we have other things that are interesting, meaningful that come out of it, I think we will email you that information as well. Although the other stuff we have planned is, it's not really so much like health related. So see people saying they're a happy participant. Thank you so much. Others saying they love participating in the trial. Yeah. As I mentioned, you guys, the thing we learned about you when we were trying to figure out what motivates you, you're all very altruistic, and you would all be lovely people to, like I said, have as neighbors or have at a dinner party. Here we go. Have you shared your findings with researchers of the other related studies? Yeah. So we've shared it in two ways. The first time that it was shared was at the end of August 31st, last year. The world's largest cardiology conference is European Society for Cardiology Congress, and it was in London that year. And it was actually great. They put us on as they called it a hotline item. They put us on the main stage. There were close to 1,000 cardiologists that were in the office. The room was packed, and we presented the results there. And then there was a second session where they were discussing. They had us on a stage answering questions, but like the room was discussing all of the trials sort of together. And I mean, again, I'm biased, but the sentiment in the room was very much that, between Time and BedMed, the answer was in, and that the belief was that it didn't make any difference. And then the papers have been published. We were waiting until the paper was published to do this webinar with you. It was published at the very end of May. BedMed was published in JAMA, which again, we're really happy. That's one of the main medical journals in the world. BedMed Frail did not get published quite so high. That population doesn't get as much attention as I think it deserves, but it was published in what's called JAMA Network Open, which is still a good journal. But yeah, so it actually got lots of attention. There were a bunch of media interviews, not so much in the media that you would see, but there were like some news that's targeted at physicians, like cardiologists in particular, and so there were interviews for those sort of groups. There's also a group called the NIH Collaboratory, which is out of Duke University, and they're very well known for facilitating pragmatic trials, developing methods for pragmatic trials. Pragmatic just means answering a question that's important to a patient or to the physician or to the people that fund the healthcare system, as opposed to just trying to prove that some new product is useful, right? So things that don't necessarily have any financial motive, but answer an important question. It will not always be the case, but I believe at the moment the JAMA article is still freely downloadable. Eventually they turn that off, and you have to be someone that subscribes to the journal to be able to see it. But if you, I'm not sure if maybe we might be able to put the link in the comments for you to see if Vera or Anna or Michael can find the link. But if you just go to the JAMA journal, like if you just Google JAMA, JAMA, oh great, yeah, so there's the link down there Farah just put. And then if you just search for BedMed, you should be able to find it. You might find both trials. pulling up BedMed. It might also pull up the JAMA Network Open, but the main one is in JAMA itself, and then you could read about the details. Okay, I'm not seeing any other questions. If you guys do have other questions, feel free to email us at the same BedMed at ualberta.ca website email address. If you're interested in the stuff that we're doing and other trials that are ongoing, we have a website that shows you what the other stuff that we're doing. You might be interested in the MinMed trial, not as a participant, but just out of curiosity where we're going. And that's www.pragmatictrials.ca. Pragmatictrials.ca, and you'll see all of the trials that we're conducting. Again, thank you so much. BedMed was the largest trial ever conducted in primary care in Canada to date, and you guys all made it possible, and we thank you so much. So have a good rest of your day.